So without further ado, I'd like to introduce Dr. Laura Martin. Dr. Martin is an associate professor in the Department of Population Health and director of the Structure and Function Unit at Hoglund Brain Imaging Center at University of Kansas Medical Center. Her research focuses on cognitive neuroscience of self-regulation, impulsivity, reward processing, and decision-making. And specifically, she utilizes cognitive neuroscience tools to understand how the brain influences health behaviors, such as smoking and eating, and how the brain can be changed through health behavior interventions. Dr. Martin also facilitates neuroimaging research by providing technical expertise to investigators and trainees interested in adding neuroimaging to their research programs.
Okay, well, thank you very much for having me here, and I look forward to talking to you about the research that we've been doing. So I'll start by giving a general overview of what I mean by health neuroscience, talk about the different neural systems that I'm specifically focused on in addiction and addictive behaviors, and then give some examples of the neuroimaging work I've been doing, looking at smoking and vaping, and then some more in health behaviors in general and more of addictive behaviors, looking at eating behaviors, exercise, and dietary supplements. So what do I mean when I use the term health neuroscience? So we know that the brain can influence the health behaviors people engage in. So, the question is there something about our brain to begin with that may make us more susceptible to addictive behaviors, to choosing to smoke that cigarette when it's offered to you as an adolescent, or choosing to vape because your friends are vaping? And then do those behaviors change the brain? And can we actually leverage the fact that behaviors can change the brain to change the brain in ways that promote healthy behaviors? So it's really that overlap between health behaviors and brain function and how these things are working together. And we can look at this across the lifespan. So later in my talk today, I'll give some examples from studies we've done in kids and adolescents, but the majority of my work is really focused on adults, and now we're beginning to move into studies looking at older adults as well and questions related to aging. So one of the questions we get asked a lot in cognitive neuroscience and as a neuroimager is really, why do we need to spend the money to use what's considered to be more expensive technology to try to understand what's going on in the brain? Why not just enroll people in interventions and see what works in terms of an intervention, in terms of helping someone quit smoking or quit using whatever addictive product that they're using? What can neuroimaging really offer beyond what we may see in studies of behavior? So what it offers is those biological and psychological markers of health behaviors in the case of the studies I'll be talking about today, as well as health outcomes. And we can use this to understand the neural mechanisms that may underlie the changes related to treatment, so that we can then target specific areas of the brain as we're developing new treatment options, and see whether we are actually engaging those neural systems with the treatment that we think should engage those neural systems, and then how are those systems changing, so that we can better develop interventions that work, and really think about optimizing how interventions may work at a more personal level if we better understand those underlying neural mechanisms. And then I'll also give an example of some studies that we've started to do, really thinking about how neuroimaging may impact public health messaging. So it doesn't have to be just about treatment. It can also be more on the prevention side of things. And as a cognitive neuroscientist, I have several different tools that I can use. My research has predominantly focused on functional magnetic resonance imaging, so putting people into an MRI and then looking at how their brain responds when we give them some type of task to do. We can also look at the brain at rest and look at connectivity, how different areas of the brain are working together. And then I've also used high density EEG system before, and I won't be presenting any of that data today, but it's another option if you're really interested in when in time things are happening, as opposed to where in the brain things are happening. So I've applied these techniques to different health behaviors, because we know that just because someone engages in one healthy behavior, it doesn't mean everything that they do is necessarily healthy. That's why I love this image of the cyclist who is smoking while out on a ride, or people going to work out and taking the escalator up when they're going to work out. So these systems are likely changing and operating differently based on the behavior or the substance that we're thinking about. And when I'm thinking about this with addictive behaviors, I'm working within a dual system model. I know that's a very generic term, but what I'm referring to there is really these midline areas and striatal areas of the brain, so those subcortical areas that are the reward processing areas, which in addiction, we know that those areas tend to be overactive. And then the regulation areas, the areas shown in blue here, that tend to be more of the lateral areas of the brain that tend to be underactive in addiction. So ideally, we would want these systems balanced so that you can respond to that reward. So, if you want to have that piece of chocolate cake, you can have that piece of chocolate cake, enjoy it, but your regulation systems are also able to help you regulate. Does that fit within your current goals? And help you decide how much of that chocolate cake do you need? Will just a bite activate those reward systems enough, and you don't need to eat the entire cake if you want to, of course, regulate that. So these are the systems that I'll be talking about today when I'm looking at addictive behaviors. And one thing that's really important to remember, especially with the reward system, and this is from a paper from 20 years ago that showed that these neural systems, so this is looking at dopamine neurons in an animal study in the ventral striatum. You can also see the same pattern of response when you look at these dopamine neurons in the prefrontal cortex. And what we see here is that when a reward is delivered, there's an increase in firing of those dopamine neurons. After an animal or a person learns that a cue is associated with receiving that reward, the increase in firing actually happens at that earlier line where you see the CS, which is the anticipation. So the cue, the flash of light, actually activates those dopamine neurons. And you can see there where the R is that there's no longer that increase in firing. And that's really important when we're thinking about cue reactivity studies, because what we're thinking about in the case of neuroimaging studies where we use visual cues is that the individual is possibly anticipating the experience of smoking that cigarette or eating that piece of pizza, as opposed to actually receiving that delivery. So we make that distinction between the anticipation and the delivery. So we can really leverage what we know about the reward systems to utilize these cue reactivity paradigms where we're thinking about how is the brain responding when someone may be anticipating a reward. And we can look at this across different behaviors. So in the case of smoking cues, we see these medial prefrontal areas. Those are the areas here at the front of the brain that you see that respond to cigarette cues compared to non-cigarette cues. So the pack of cigarettes compared to the pack of pencils, and that the way the brain responds can change based on when the individual had their last cigarette, how many cigarettes they smoke per day, the time until that next cigarette, whether or not those cues are personalized. So some studies have actually had individuals take a camera home, or now they could use their cell phone, take pictures of where they usually smoke around their house, and then use those images in the scanner instead of pictures of cigarettes. And you see that just seeing the environment with cigarette packs and ashtrays removed activate these same areas, just as if you were showing an actual cigarette cue. And in studies of eating, we see differences in how these areas respond with body mass index, time since the last meal, time until the next meal or the next cigarette. All of these things can change the way these systems respond, which is one of the benefits and one of the challenges of functional neuroimaging, is that these systems change and they are influenced by everything else that an individual may be bringing with them when they go into the scanner that day, in terms of what else has happened to them in their day already. And so I'll be talking about my studies looking at smoking, and then go into some studies of eating and exercise that we've done. So the first study is a really small pilot study. We were interested in understanding how the brain, how these neural systems of reward change with cognitive behavioral therapy that's delivered before cessation. And it's important in this case that we were looking at this before sensation because we wanted to look at how the brain was changing in response to smoking cues, but not show people smoking cues while they were in the middle of a quit attempt. So participants came in at baseline. They went into the scanner, looked at passively viewed pictures of smoking images and non-smoking images, and then went through 4 weeks of group cognitive behavioral therapy centered around what they would do to prepare to quit smoking. We also asked that participants over this 4-week period begin smoking their cigarettes on a schedule as opposed to whenever they wanted to. This is a way to engage those regulation systems and start to separate the, I have a craving for a cigarette right now, and that will be rewarding from actually the delivery of that nicotine. So by separating that in time, it engages those regulation systems. So this is a very small pilot study in 6 participants, but what you can see is if you focus on the dark lines here, the DLPFC, so one of those regulation areas, showed increases from baseline to 2 weeks into the treatment, and it stayed elevated at the 4-week period, but had gone down a little bit. The dorsal medial prefrontal cortex, which is another one of these regulation areas, increased across time there. And then the ventral medial prefrontal cortex, which is the reward area, showed a pattern of decreasing in response. So it seems like we are potentially rebalancing these systems with cognitive behavioral therapy prior to a quit attempt by increasing the regulation and possibly decreasing those reward systems. We followed up on this study using a randomized design where participants were randomized to CBT for smoking versus CBT for trying to increase fruit and vegetable intake to see whether this was specific to smoking. And we changed the design a little bit, and the results of that study were less clear in that we didn't have differences necessarily between the CBT for smoking and the CBT not for smoking. So we're still looking through those results, trying to figure out exactly what that means. So it could be that CBT is transferring to all behaviors, and so we're changing the regulation systems in general, and it translates to when you view smoking cues. But we'd like to do a larger study to really understand what that means, because again, this is a very, very small pilot study just to show proof of concept. We took this idea of can we actually change those regulation systems and applied it to my COPE study that was funded by the American Cancer Society. So COPE in this case stands for CO Practice Experiment. So what we did is we actually had participants randomized to either practice delaying their first cigarette of the day, which is the hardest cigarette of the day not to smoke if you are a smoker, versus a no practice comparison. And in order to do that, we sent participants home for a week with a CO monitor, had them blow into it when they first woke up, blow into it again right before their first cigarette and right after their first cigarette, so that we could understand when they're usually smoking their first cigarette of the day. And then they came in, went into the scanner, did another cue reactivity study and did a cue reactivity study in the scanner so we could get their brain activation. And then they were randomized to the practice or no practice. The practice group was asked to delay their first cigarette, as I said, and that was customized to when they usually smoke their first cigarette. So if they usually smoked within a few minutes of waking, their delay was much shorter than someone who smoked within 30 minutes of waking. And we limited that to everyone had to smoke at least within an hour of waking to be eligible for this study, so that we could titrate their practice level at the individual participant level. In this task that we used in the scanner, we also asked participants to actively or not actively regulate their response to those smoking cues that they saw. So they got these instructions of negative right before seeing a smoking cue, or a non-smoking cue, which in this case was food. If they saw the word negative, they were asked to think about the negative consequences of consuming the item. So if it was a cigarette, this will make me cough, this will make me not live as long, my kids really want me to stop smoking. I don't like the smell, those sorts of things. And if it said positive instead of negative, they were asked to think about the positive consequences of consuming the item. So that may be a cigarette would make me less stressed right now, a cigarette would taste good right now, so that we could see what was happening when they were actively regulating those responses. And then we had them randomized, as I said, to those 2 practice groups, and then come back in after 2 weeks of progressively delaying their cigarette for that follow-up scan. In the baseline data, we did see dorsolateral prefrontal cortex that responded more when individuals were asked to regulate versus not regulate their response. So the task was picking up on engagement of these regulation areas when actively regulating. And we saw that for both the smoking and the food cues, when individuals were asked to regulate, they reported that they wanted those items less than if they were not actively regulating their response. And then at our follow-up scan, what we found is that those in the practice groups showed increases in this lateral area of the prefrontal cortex from baseline to follow-up. And those increases also correlated with their ability to adhere to the delay that they were prescribed. So now I'll shift gears and talk more about the prevention side. So we've done a couple studies now looking at how adolescents and young adults respond to advertisements or marketing for vaping, to understand how the brain is responding there and then whether or not we can change that. And we're, of course, interested in this because of the increased rates of vaping among adolescents that are around 20% right now compared to the use of cigarettes, which is very, very low among adolescents. And so our first study simply looked at what happens when an adolescent or young adult, so this was ages 14 to 21 in this study, view a vaping related ad compared to a control ad. And these ads were matched so that they were using similar marketing appeals in the advertisements. And what we found is that the vaping ads showed greater activation in these medial prefrontal regions compared to the non-vaping ads. And so we wanted to take that to the next step. So my colleague Yvonne Chin, who's in the School of Journalism and Mass Media, has done a lot of work looking at media literacy training. So could we actually apply a media literacy training intervention to change the way adolescents are responding to the ads? And what media literacy training does is have individuals go through exercises to critically evaluate the ads that they're seeing. So instead of just looking at that ad, they're thinking about, why is the company advertising to me? Why is this ad set up in this way? What is the company trying to convey? What are the goals? How does that relate back to me? And usually this is done in an hour to 2 hour in-person group session where adolescents talk through this, they look at different ads, they walk through critical thinking exercises. And we wanted to see whether we could do this with a really brief set of media literacy messages. So what we did is we first put together some messaging about, what some of those critical thinking messaging patterns. We took those to a focus group at Children's Mercy Hospital here in Kansas City to get adolescent feedback on whether or not they were receptive to the messages that we were putting together. And the feedback we generally got is, it needs to sound like a fact, not be an opinion. So not companies want you to try this because they're not interested in your health. Actually put some data behind that was the feedback that we got from adolescents. So we took that feedback and put together a set of about 20 messages and played those in the scanner. They were presented so that participants could see the visual text of the message and then also heard an audio recording of that message. The messages lasted a total of about 5 minutes to play all of these 20 messages. And these messages included things like, e-cigarette companies only care about making money and they will do everything they can to get young people like you to use their products Do they really care about you? So there's also some questions built in there to really hopefully get the participants to think a little bit more critically about these ads. And what we found is when we showed these ads pre and post, we did see changes to the vaping and the non-vaping. So post ad, we did see changes in the DLPFC as well as the VMPFC. So the regulation areas were changing. In this case, it was less of a deactivation, and the reward areas were also decreasing. So if we had just looked at the difference here, it would appear that the DLPFC is increasing and the reward areas are decreasing, so that those systems are potentially working together. The challenge here is that we did not have a control condition or control intervention to be able to really say whether these changes are specific to media literacy training versus something that would just happen if you kept a participant in the scanner across, 4 runs where they're looking at these ads for about 20 minutes. So we can't really get at that habituation question. We have gone back and compared the same amount of ads pre and post to our previous study just to get a sense of whether these effects hold up. It's not the best comparison because there's not really a control intervention there, but we do still see that the DLPFC activation does seem to be specific to media literacy. The VMPFC activation was changing in our previous study as well when we looked across the multiple trials that participants went through. So we need to do some more work to really understand whether that effect is specific to media literacy, do that randomized control trial so that we can compare those. We did see changes in media literacy scores. So participants did report that they were more media literate after going through the media literacy training. However, we did not see changes in susceptibility. So that's something else that we're working on in future grant applications to see what do we need to do to really move that needle, and is that a matter of the participants that we recruit focusing on people who have possibly experimented with vaping and have somewhere to move with their susceptibility, or focus on people who have never vaped, which the majority of our sample in this case were people who had never vaped. So I know I threw a lot of different ideas at you. I really wanted to show some different types of studies we can do both on the intervention and prevention side. And now I'll share some of the results that we've worked on around weight management and exercise interventions. These studies were led by Carrie Savage, who's at the University of Nebraska, and Joe Donnelly, who manages the weight management program here at KU Med. And what we did in this study was have participants go through a 3-month weight management trial and look at their brain activation to food cues pre and post. So very similar to what I've done in smoking. And what we found was that at baseline, individuals who activated their dorsolateral prefrontal areas more to food cues were the ones who successfully lost weight. So we do see that, and it also is associated with increased adherence to the intervention. I have looked at these data as well to see whether there's differences in the individuals who maintain versus regain weight. And what we found is that in those individuals who regain weight from baseline to, or after they've gone through the intervention, so everyone lost weight on this 3-month intervention. And those who regained weight actually showed increases in their response in these reward areas during the weight management trial. So individuals who actually increased their response to food when they're on a very controlled diet were those who were more susceptible to regain. And then we also looked at connectivity. So how the DLPFC and VMPFC are working together, and found that those individuals who were able to maintain their weight loss showed increases in their connectivity between these 2 regions. So these regions are communicating more, which may be facilitating their weight loss and weight maintenance. We've also looked at this in exercise adherence, and we don't have a lot of data out of this study yet. But I've looked specifically at how these reward systems are changing when individuals are enrolled in a 9-month exercise intervention, and specifically focused in on the striatal regions. So these regions that respond more to the anticipation of rewards. And in this study, we didn't use cue reactivity. We used a task that mimics more of that earlier slide that I showed you, where animals learn that a cue predicts that a reward is coming. In this case, we had a cue come on the screen that predicted whether or not the individual is likely to win money or lose money, followed by feedback on whether they won or lost money. So the results that I'm showing today are really focused on that cue period. So when they're anticipating that they're likely to win money. And what we found was that in those individuals who adhered to the intervention, so that meant they actually completed the majority of their weekly prescribed exercise, which included a combination of in-person exercise, in-lab exercise, as well as exercise at home. Those who were able to adhere to that intervention showed actually an increase in their nucleus accumbens response, so their anticipation of reward. And these were individuals healthy weight to obese. And I've thought a lot about these results and what these may mean, why we're seeing this increase. And if you remember from that very early slide that I showed you, over time, when someone learns that the cue shows increases in dopamine-related firing, that is the normal pattern once you've learned. What we've seen when I've used this task in smokers is that this doesn't necessarily, there may be a dysfunction and this anticipatory reward among individuals who smoke or who are overweight, so that they don't show this anticipation related response. They actually respond more to the delivery of the reward as opposed to the anticipation. So this adherence piece here may be related to normalizing that reward system. Again, this is very preliminary data at this point. So I'm open to other ideas of that anticipation, but that's what I'm thinking right now, is that by adhering to exercise, we know from studies in kids and studies in older adults, exercise increases executive function, increases those regulation-related brain responses. So we might be seeing these changes relating to more normalizing the reward response. And then we've also looked at, in the food-related area, using guided imagery to increase healthy food choices. So having participants think about their future healthy self, making healthy decisions. So using a technique called episodic future thinking, where you're asked to imagine yourself in the future. And we had participants go into the scanner, listen to this guided imagery in the scanner, and then looked at brain activations to food cues, pre and post this guided imagery. Very small sample size again here, more of a proof of concept, but we did see some dorsal medial, prefrontal, more premotor areas that showed changes with this guided imagery. I'd really like to do this in more of a controlled trial where we also have not just the episodic future thinking, but an episodic recent thinking that we can compare that to. The other thing is we did see changes in their food choices afterwards. So after they were done with the scan, we had them sit down in a room where we had food out on the table for them, and they could choose as many of those snacks as they wanted while they filled out some follow-up questionnaires. And we did find that after the guided imagery, individuals chose more healthy than unhealthy foods. Again, unfortunately, we don't have a control condition here to be able to know that that is really related, that is different than what it would have been otherwise. So that is something else that we are following up on. And then finally, I want to present these results looking at supplements and how our nutritional health may be forming our brain to begin with and changing our brain. So we had the opportunity to bring individuals back who had participated in a study when they were infants. So these kids, when they were born until they were 1 year old, they were randomized to receive their formula with different levels of DHA. So those good, healthy omega-3s that we know are really critical for brain development. So they were randomized to receive either formula with no DHA in it or varying levels of DHA. And this study that was done here at KU Med by some of my colleagues, as well as other institutions, was really what led to DHA being in all infant formula now. So we couldn't repeat this study now because DHA is now in all infant formula. And so they had seen changes in brain development, changes in cognitive performance within that first year of life and at 5 years, and they were still in contact with these families. And so we said, why not bring them in and see whether we still have changes when the kids are 8 to 10 years old and have them go through an MRI. So we did a multimodal study where we looked at brain structure, which is shown here in figure A, brain metabolism, so using magnetic resonance spectroscopy, and that was placed over a similar area to where we see this task-related activation, and then they also did functional MRI. And what we saw is that this group that had received supplement of DHA showed increased task-related activation, increased structural white matter within these regulation-related areas. So supplementation that happens in the first year may actually be impacting what's going on in the brain 8 years later, after the individual has not necessarily been taking that supplement. So it's intriguing. Of course, we would like to see whether this holds up across further studies, but gives us an idea that even very early in life, what's happening in terms of health behaviors may in fact be changing the brain. So I've gone through a bunch of different studies looking at how the brain may be changing. As I said, we're also beginning to move this into older adults, looking at whether, so there's been a lot of studies, like I said, on exercise intervention, but how increasing adherence to exercise, how changing diet may help prevent the development of Alzheimer's or other related dementias. Of course, there's a lot of people who contributed to the studies that I presented.